It was a great surprise to me to be on an advert on CNN. One of the splinter groups, a think tank, a right-wing think tank from the Republican Party, came over and wanted to do a video talking to various people in the NHS in Britain. And I was selected as the cancer person, knowing that I'm pro-reform of the NHS. And, it seemed reasonable. Everything I said when I looked at the video clips was reasonable. And blow me, they appeared not only on CNN but on YouTube as well, within a framework of an advert. And I didn't know that was going to happen. When I look at the advert, there's nothing I've said there that I'm either ashamed of or regret. It's all, to me, completely true. But it has caused a little bit of a problem with Imperial College, where I do my clinic. They don't really understand what it's about. And it does appear that one of the priests of the NHS is saying he doesn't believe in God, which is the religion of the NHS. The US have got two problems. One, the lack of insurance for around 50 million people. So it's not a universal healthcare scheme. The second is it's too expensive. And that's what Obama's trying to sort out. And that's the health reform he's trying to do. I think they're looking, as you would, at all healthcare systems, European, South American, even Indian systems, to see how you can get both. I mean, it's criminal that a civilized country, well, relatively civilized, such as the US, can have 50 million people that have no health insurance. And the discussion whether they can actually give their kids chemotherapy for leukemia and so on is just outrageous. So I think they've got to do that. How they do it is another way. Now, the extreme version is a single payer, government payer, and a single provider, government hospitals, which is more or less what we have in Britain. To me, that's an awful idea, and I sympathise with the objectors to that. I don't sympathise with the idea that you're just going to let these people have no insurance, but single payer, single provider is not the way forward. It's inefficient, it's bureaucratic, it doesn't give patients choice. And I think it won't happen under Obama. They'll look for a different solution. But I think the problem is you've got the centre-right pulling one way, wanting complete privatisation, and the centre-left wanting state monopoly. And the answer's got to be in the middle somewhere. I think the biggest problem we've got in cancer is NICE. Cancer drugs account for less than 2% of the drug budget in the UK, and yet report after report, comparator reports looking at patient access to cancer drugs show that we're bottom of the pile consistently, tenfold less for many of the drugs that have come out in the last 2 years compared to, say, France or Italy. Even last week, sorafenib Nexivar was turned down for hepatoma. It's been available for 2 years in all European healthcare systems. Complete bureaucracy and complete inequity. If you know how to manipulate the NHS, you can probably get it. You have to be intelligent, vocal and demanding, but not rude, and you can get things. If you don't have these sort of skills, you won't get it. If you don't ask in the NHS, you don't get. It's just a tragedy. And I think it's all to do with government control. If you look at breast cancer, Herceptin, even administered before it was even considered by NICE, simply as a political solution to gain votes by Patricia Hewitt when she was health minister 2 years ago. You can't do medicine by politics. You've got to separate the two. And I think the potential is that if you pick up some of the good things of the NHS for the state, which there are good things, what you don't want to do is pick up the bad things as well. But of course the hierarchical structure and the bureaucracy get very worried when a British doctor is on American TV saying that sort of thing. Both Conservatives and now Labour have the right idea. They both want to introduce choice and competition to let the system evolve. So the Conservatives called it purchaser-provider split. Labour call it payment by results and patient choice. Exactly the same concepts. Driving competition, as you have in every other walk of life, whether buying a cup of coffee, getting a mobile phone and so on. There's choice and competition out there. The critics would say, well, you can't do that for cancer care. I would say you can. You can do it for everything. You split the journey up, diagnostic phase, treatment phase, surgery, radiotherapy, chemotherapy, and you provide competitive providers of services, and they compete just like budget airlines compete with established airlines. And you find you get better quality service, not only in the budget airlines, but also in the other carriers, because they're competing. Whereas, British Airways used to have a monopoly, just like the NHS. The NHS still has a monopoly, and I think getting rid of that monopoly is the way forward. I think what we're looking at is splitting up the provision of treatment. So you have radiotherapy providers, you have diagnostic MRI scanning providers, which we already have. The diagnostics have already been split up. The coordination of care and the regulation of care has to be done by a physician, an oncologist. And increasingly over the last decade, doctors have lost control of how patients are managed in systems. They've lost control of prioritisation. When I was first to consult, it was up to me who I brought in the next day for chemotherapy or for radiotherapy. Now, complex series of targets with managers, administrators trying to follow, and patients and gaming with the system. So patients that need urgent treatment are put to the back of the list sometimes because it's better to treat financially a lot of simpler, non-urgent patients first before getting to the urgent. It's not just in cancer, it's in all walks of life in the NHS. And I think we as doctors, my generation of doctors, have really lost control. I think in most countries that have them, including Europe, the satisfaction level and the capacity levels are much greater than here. I mean, it is ludicrous to have a 31-day target from diagnosis of cancer to the first treatment. No European country would do that. And in America, you'd sue still if you had to wait a month to get started on treatment. Here, that's the aspiration. It's not going to be met for many patients because we don't have the radiotherapy capacity to do it at the moment. So I think public-private partnerships are a way of quickly injecting capital and paying for it later. It's a sort of hire purchase, if you like, of a service, but not to lose the consultant's control of the patient pathway throughout, so there's complete integration. The British private sector is incredibly small. Less than 15% of patients have insurance throughout the NHS. But if you look at the US, the majority of cancer services are actually private sector. All the big cancer institutions, MD Anderson, are private institutions. They may not be for profit. Some of them are, some of them are not. But they're essentially private sector, providing insurance-based services, including to Medicare and Medicaid for the older and the very deprived patients. So the model works there. It certainly works in France, where you have a plurality of providers. Here it's more difficult, and we're starting really from ground zero, if you like. But I think we'll get there. It's sort of inevitable because we can't afford to allow continued inefficiencies taking up so much of our resource. Prevention is really the holy grail for the future in cancer. And it's interesting that, having been for 12 years a clinical director of the NHS Cancer Centre at Hammersmith, no service that we did there was anything to do with prevention. I think we're going to see a change because of new technology, biomarkers to measure cancer risk, and then cancer preventive drugs coming. And once we have those two, rather like cholesterol and using statins, we'll be able to reduce cancer. But it's going to take 20 to 30 years before we see any effect of that. You can't get cancer risk reduction quickly. Even if everyone stopped smoking, the cancer incidence for lung would go very slowly over the down. So it's not going to save our bacon in terms of money. We've got to look at how we spend the cancer money more efficiently in the UK and similarly in the US. The way I can see it going is, first of all, you have to identify who's at greater risk from getting cancer in populations, so you don't have everybody. We know the average risk is 1 in 3, but almost certainly, if using in the next few years low penetrance cancer risk genes, you'll be able to identify a population that may have a 1 in 1 or 1 in 2 chance of getting cancer. You take those out, and then you do clinical trials. You search for some biomarker. It would be lovely if it was a blood sample that you just take it, rather like cholesterol, and that gives you cancer risk. It may be a combination of patterns of gene switches, and there are technologies out there to look at those in the blood. The studies, the technologies we've got for the early detection of cancer mammography, cervical cytology, and fecal blood for colon cancer are very crude, and obviously a lot of the tests are non-specific, and you have a very expensive phase of downstream investigation, which is very worrying to to people that may or may not have cancer. So we need better tests, and I think they'll come from technology. And if we can sequence someone for $1,000 for the total genome, which looks likely now, then and store that data, then almost certainly we'll be able to identify high risk and low risk groups and tailor our prevention and screening programs.